All right, I'm excited to introduce our speakers for tonight. We have Dr. Debbi. He's a hip and knee replacement surgeon at HSS. He's an expert in minimally invasive hip and knee replacement surgery, including anterior hip replacement, total knee replacement, hip resurfacing, and partial knee replacement. Dr. Debbi has particular expertise in providing the latest computer-assisted and robotic surgery for his patients. He has a passion for investigating and developing new technological innovations for joint replacement. We also have Danielle Schuman joining us. She's an orthopedic physician assistant at HSS, and she's taking care of patients both pre and post-op, as well as assisting in surgeries. She graduated from Pace University's physician assistant program in 2021, and she's worked at HSS ever since then. So before we get started here, I am just going to go over the program agenda really quick. So we are going to start with some presentations from our speakers. Danielle is going to go over the anatomy of the hip, and then we'll go into the causes of hip pain and the treatment options. And after that, we'll tackle some of your questions. All right, so I'll hand it over to Danielle to get started with the anatomy.
All right, thank you, Bonnie. So I'm going to get started off with some anatomy of the hip. So we can go to the next slide. So the bones that form the hip include the ilium, ischium, and pubis, as we could see in the top picture in the red, yellow, and purple. The hip joint is classified as a ball and socket joint. It consists of the acetabulum, which is the socket located on the side of the pelvis by which the femur fits in. The femur is the thigh bone, which is the longest and heaviest bone in the body. Being that the hip is a multi-axial ball and socket joint, enables us to have the range of motion, allowing us to move forwards, backwards, side to side, as well as up and down. There are ligaments, tendons, and muscles covering the hip joint that allows for weight-bearing stability and movement. Lining the femoral head and acetabulum is articular cartilage, which we could see in the bottom picture. It's connective tissue, which is about 2 to 4 millimeters thick, and serves as a source of shock absorption, as well as a smooth, lubricated surface in which the femoral head can easily glide within the acetabulum, so the socket. This tissue has limited ability for intrinsic healing and repair, though, since it lacks blood vessels and nerves to that site. Thus, once the cartilage is damaged or worn out, our bodies aren't capable of naturally growing new articular cartilage. The labrum is a fibrocartilaginous ring-shaped structure which lines the rim of the acetabulum, so the socket. It serves to provide a deeper socket for the femoral head, greater stabilization, and serve as a shock absorber to the hip joint. It also provides a sealing rim around the joint to facilitate lubrication and resistance to joint distraction. It's innervated by 2 nerves, so if it's injured, it can be a source of pain as well as clicking in the hip joint. So ligaments are fibrous connective tissues which connect one bone to another, as well as provide stability to a joint. There's 3 major ligaments that form the hip capsule. It includes the iliofemoral, pubofemoral, and ischiofemoral ligaments. The spiral fashion by which the ligaments are organized serve to prevent the hip from hyperextension or dislocation. The anterosuperior aspect of the hip is where the capsule is the thickest, as that is where most weight-bearing stress occurs. The ligamentum teres is a small ligament connecting the femoral head to the acetabulum, the socket, and its primary role serves as a secondary stabilizer to the hip joint. Tendons are strong, flexible connective tissues, primarily made of collagen, which serve as the connection of muscles to bones. All the muscles of the hip originate and insert along sites of the pelvis, femur, and tibia, which is the shin bone. Of note, the iliotibial band is a thickened band of fascia at the side of the thigh, which serves as a connection to many large muscles of the hip. And then a bursa is a thin sac of tissue which contains fluid to help lubricate areas and reduce friction between bone and soft tissue. The bursa is naturally produced by the body in response to repetitive pressure or stress over a bone. There are approximately 18 bursae in the hip region. Some of the more important include the greater trochanteric bursa, iliopsoas bursa, and ischial bursa. So there's about 21 muscles crossing the hip joint, which allow for movement and stability. They're categorized by their function. So as we could see here, hip flexors, extensors, abductors, adductors, internal rotators, and external rotators. The hip flexors allow for movement of your knee, for example, towards your chest. The muscles there are listed. The hip extensors allow for movement of your leg behind you, as you could also see in the image below. Hip abductors allow for movement of your leg out to the side as if you're going to do like a side lunge. Hip adductors allow for movement of your leg, for example, if you're going to go from a side lunge back to center, standing up straight. External rotators allow for you to sit, for example, with your legs crisscross. And internal rotators allow for twisting movement of your thigh inward towards your hip. So here, for example, circled in red are examples of muscles belonging to that certain category, like the hip flexors, the psoas muscle, iliacus, pectineus. And below is an image kind of showing the movement in which these muscles play a role in. We can go to the next slide. So here again are examples of the abductors, external rotators, as well as internal rotators. All these muscles serve to coordinate and enable the hip to move in all different directions. So for flexion, it allows for flexion of the hip to about 120 degrees, extension to 10 degrees, abduction to 45 degrees, adduction to 25, internal rotation to 15 degrees, and external rotation to 35 degrees. So hip pain is a common complaint among adults. The prevalence of hip pain in the general population is about 10%, and prevalence of chronic hip pain is about 30 to 40% among adults involved in sports. The largest source of hip and groin pain in active adults involve injury to extra-articular muscle and tendons. Hip pain can be very disabling and definitely interfere with many activities of daily living. Hip pain is categorized as orthopedic or non-orthopedic causes. For example, certain skin conditions or vascular conditions or gynecological causes may elicit hip pain. Hip pain can also be categorized as intra-articular and extra-articular. For example, intra-articular within the hip joint would include arthritis or a labral tear, whereas extra-articular outside of the hip joint causes include like ligament strain, muscle tear, or even sciatica. It's crucial to pay attention to your symptoms and be as specific and detailed as possible when presenting symptoms to your provider. The onset of hip pain is often the first question that's asked, like, how long have you been experiencing the pain for? When did it start? Was it sudden? Like, was it a trauma or an accident, or gradual, meaning that it may have started spontaneously one morning and progressively worsened? It's important to acknowledge if there are any factors that provoke or improve symptoms. For example, does squatting or jumping worsen your pain? Do non-steroidal anti-inflammatory medications, rest, and certain positions improve your pain? It's important to be able to also describe the quality in which you experience the pain. Is the pain sharp, stinging, stabbing, or is it aching, dull, burning, pressure? Paying attention to the exact location and pattern of pain is crucial. So does the pain radiate? Does it kind of start in the front of the hip and radiate to the groin? Does it start at the side of the hip and maybe radiate to the lower back? Can you localize specifically where you are experiencing symptoms. Although you might be experiencing hip pain, the etiology of pain could be originating from a different part of the body, such as the back or other organ in the body. Describing associated symptoms can also help narrow down the diagnosis. For instance, along with the hip pain, are there any locking or clicking noises? Do you feel kind of like a catching or an instability when you do certain activities? Is there numbness or tingling in your leg? Are you experiencing systemic symptoms such as like fever, chills, fatigue? And then lastly, time course in which you have been experiencing the symptoms is helpful in understanding to what extent is the hip pain interfering with your daily activities and daily life. If the pain is intermittent, or how long does it last for at like certain intervals. Having a good understanding of the history of the hip pain enables for a better understanding of the underlying cause and origin of pain, along with physical exam and further imaging if warranted.
Thank you, Danielle. That was very detailed and very thorough, and I think gave a very nice introduction to the hip anatomy, causes of pain, and what we should be on the lookout for. So thank you for that. I think that sets us up very well for the next portion of the talk. So my name is Eytan Debbi. I'm one of the hip and knee replacement surgeons at HSS. I focus mostly on hip and knee replacement, but obviously see patients for all sorts of reasons related to their hip. And as you heard from Danielle, the hip is a very complex joint. And at the end of the day, the most important thing is to be seen by clinicians such as myself, such as Danielle, such as another clinician, to help you out and figure out what's going on. And sometimes it can be very frustrating. The hip is one of the biggest joints in the body, and it can be very painful when you have the pain. We need the hip for almost all activities we do. So, just the demonstrative slide of the kind of patients I see patients of all sorts of ages, and patients have high levels of activity, high levels of expectations. And unfortunately, hip pain can be very debilitating, whether it's to run up a flight of stairs or even to just kind of hang out with your grandchildren or do yoga or pickleball, if that's what you do. It seems to be a hot topic nowadays. But obviously, hip pain can be very detrimental to that. Next slide. Hip pain, when I see patients with hip pain, it's very difficult to describe. I think that the term hip pain is this overarching term for pain in the region around the hip. And as Danielle said, it's really important to kind of think about where is the pain coming from, and what happens or what am I doing when I have the pain? Is it groin pain? That's important. Is it pain on the outside of the hip? That's important. Is it pain in the buttock region? That's important. Is it pain going down the leg? That's important. Is it pain at rest or activity? So all these things are really important to keep in mind, and to kind of keep track of, because you may not see a physician or a clinician after one incident of pain. So it'll likely be a few episodes of pain, and to keep track of that would be really important, and especially help us better diagnose and better treat you. Next slide, please. So there are a lot of potential causes of hip pain, and this is really not a extensive, exhaustive list, and we could be here for all hours, of the night discussing the potential causes of hip pain. But I think these are some of the most common causes of hip pain that I see. And each one has kind of different levels of severity on your function, and different interventions that we can possibly provide you with. But obviously, all this has to do with all those anatomic structures that Danielle went through in such great detail. And each of them kind of has their own separate treatment management. So we'll talk about bursitis, impingement, labral tears, muscle and tendon injuries, and we'll end with osteoarthritis, which is really my specialty in terms of surgical management. So let's go to the next slide and we'll discuss bursitis. So bursitis is basically inflammation of these sacs around the hip. So your whole body has these little sacs around their joints. And the whole reason that your body develops these sacs is to have a little bit of fluid and lubrication around all these muscles, transversing your joint. So in the hip, there's a few different sacs that are important. There's the iliopsoas bursa, there's the greater trochanteric bursa, there's a bunch of other few bursas around the hip. And they function normally. So having a bursa is not the abnormality. But if you're highly active, and you have an injury, or you fall, or you have some sort of twisting issue, or you're playing a lot of sports in a row, you may have some pain and inflammation around the hip. In fact, probably the most people that are now logged into this call have had some sort of inflammation or bursitis around their hip. It usually is transient. It goes away with a little bit of rest. But sometimes, if this becomes more repetitive, then these bursas can be quite frustrating. They can enlarge. They can create a lot of pain and inflammation. Usually, the pain is on the outside of the hip, kind of where you can actually touch the outside of your hip, and you can actually hurt if you feel pain. You can actually touch the outside of the hip, and that causes you discomfort. That's typically signs of bursitis. Not an emergency, not a surgical emergency, usually not treated surgically. We'll talk about potential treatment options, but that's usually some sort of inflammation around the sacs of the hip. The most common being bursitis relating to the greater trochanteric bursa. Next slide, please. Another common issue that we see are what's called labral tears. The labrum of the hip is actually a really fascinating structure. It basically acts as a gasket to this ball and socket joints. And it provides the hip with not only stability, but a little bit of suction in the hip, and nice fluidity of motion. What can happen with time, not only with age, but also injuries, you can have tears of your labrum. And these can be traumatic tears, like in a football player or a soccer player. They can be atraumatic tears, what we call degenerative tears of the labrum as you get older, within the realm of normal. And we see them basically at all ages. And each one has a different treatment algorithm. The most common area of tearing of the labrum is really at the top corner of the hip, because as you kind of bear weight on the top of your hip, that top labrum is oftentimes what can tear. And if you suspect a labral tear, the symptoms can be very challenging to pinpoint. Sometimes they're groin pain, sometimes it can be pain on the outside of the hip, the back of the hip. Typically, your physician will try to move the hip and actually try to squeeze the labrum with motion of the hip. It'll help us diagnose and capture which part of the labrum may be affected and torn. Typically, if this is what we think is going on, the x-rays don't always show any changes or issues, and your surgeon or clinician may consider getting an MRI of your hip, because we can't actually see soft tissues such as bursa, muscles, tendons, or the labrum on x-rays. The MRIs really help us. The images that you see here, one is an x-ray, the other is the MRI. The MRI is what gives us all those details, and you can see here a labral tear. What can happen very commonly is that we have patients with hip dysplasia, which means a little bit of a shallow socket. Oftentimes that's congenital, you're born with that, but as you get older, that puts extra pressure on that labrum, and it can eventually tear. There's a bunch of different treatment options for labral tears, and it really depends on when it occurred, what your age is, what your baseline function is, and how much it's bothering you. Another important thing to factor in is, do you have something like hip dysplasia, or do you have something like arthritis around the hip? Next slide, please. So another issue that we see commonly is what's called impingement. This is femoroacetabular impingement. Basically, this issue is some sort of deformity around your hip. Many times you're born with these deformities and they don't really bother you for years, but as you get older, or you're very active, or you have an injury, they start coming into play. These are kind of very classic examples. On the left side of your screen, you'll see a pretty typical hip, a nice, circular curve, a nice circular femoral head. With no significant arthritis. But on the right side, you'll see that femoral head isn't perfectly circular. And what happens is when that occurs, that fluid motion that Danielle described that occurs in this kind of ball and socket joint just becomes a little bit abnormal. So it's not really a perfect ball in a perfect socket. And these are, the center of the screen, you'll see kind of different versions of these deformities. There's cam deformities, there's pincer deformities, but generally this is some sort of deformity around the hip that can begin to become bothersome, because what can happen is what we call as impingement. Basically, the bones or the soft tissue start squeezing each other. Doesn't really matter too much at the beginning, but eventually with repetitive motion or repetitive injuries, these can become bothersome to you. And can create issues like we'll discuss in the next slide, like arthritis, or can create issues like labral tears, which we discussed previously. So oftentimes these kind of all come into play. Different treatment options for this are similar in that we really want to know what your age is, how much is it bothering you, the severity of the deformity, and what are the injuries around the hip as well. But this can be a common cause of pain, oftentimes very similar issues with pain with certain motions around the hip. Let's go to the next slide, please. Another common thing that we can see are what's called muscle and tendon injuries. So we just discussed all these muscles that not only cross the hip, but they insert around the hip or originate around the hip or insert and originate in the hip itself. And obviously all of these muscles and tendons have really important function. The title of the talk is kind of pain in the weekend warrior. Muscle and tendon injuries are one of the most common issues we see in what we call weekend warriors, which means essentially what that term means is that you're highly active on the weekend or highly active on your off time. So what I always encourage people to do, and this is not just patients, this is anybody, and actually I have to remind myself, really important to really warm up, do your stretching exercises, go into, strenuous activities slowly, build your muscles up. Because the worst thing that can happen is you go from full rest to very high level of activity. That's when we start getting worried about potential muscle tears, tendon tears. So those are kind of really important things to keep in mind. The majority of these are managed without surgery. So the muscle's torn, we have to repair it, or the tendon's torn, we have to repair it. It really depends on how much is torn. Do you have any weakness? Many times these tears are minor and can resolve without surgical intervention. But you really want to meet with the clinician if the pain continues to bother you, especially if you're having weakness around the hip, because then we want to see what these muscles and tendons look like. It's going to be really important to get a good physical exam to see what your strength is. And also, if we need to, we can get things like x-rays or an MRI to see how bad that tendon is. If the tendon is really torn off the bone, in many cases, we consider repairing it. But when I think of the weekend warrior, especially in younger patients, this is something I think about a lot. Really important to warm up before all activities. Let's go to the next slide. So one of the most common and kind of the last one we'll discuss in detail is osteoarthritis. So this is probably the most common issue that patients see me for. And what is osteoarthritis? Basically, it's wear and tear of the hip. Patients are very active. Thankfully, patients are living longer. We all are. We have better healthcare nowadays. Patients are more active in later years in life, and that's good. We want you to do those things. No one's saying that you shouldn't do that. In fact, I always encourage patients to live their best life. You have one life to live. Go out and live it. With time, you may have wear and tear of your joints. Some patients, if they have genetic issues, if their parents and their grandparents had arthritis, they may have arthritis at an earlier age. But arthritis is something that we can expect as you get older, which is wear and tear of your joint. And this basically means thinning of the cartilage, that nice cartilaginous cap that Danielle showed in her slides. And with time, that wears and wears and wears. And it's slow at first. Generally, arthritis is slowly progressive. So it's not like one day you wake up and your hip is now severe arthritis and the day before it wasn't. It's very rare. And you slowly develop arthritis. And what happens as the cartilage eventually wears out completely, you get what we call bone-on-bone arthritis. So this X-ray you see here, pretty clear. The hip all the way on the left side of your screen, which is actually the patient's right. You can see the nice ball and socket joint like we saw earlier with space between the joint. But on the other side, you can see that hip is now completely worn out, and actually that nice femoral head is completely wearing against the acetabulum. When that occurs, patients start having pain on a regular basis, pain with every motion, difficulty doing their daily activities. that kind of mild arthritis transitions to the point that really every day it's interfering with your quality of life, and you start requiring some pain control medication to take care of the pain as well. And that's when patients typically see me, is for end-stage arthritis. Next slide, please. So let's talk about some treatments. So I think, all the slides we went through here, generally, starting with non-surgical intervention, with some exceptions, is generally an acceptable way to start, okay? There's anti-inflammatory medications, there's physical therapy, there are injections that we can provide, and that goes for all these issues. And sometimes the injections are in the hip, sometimes they're outside the hip, and sometimes just, a simple anti-inflammatory like Advil or Aleve can actually go a very long way. And in fact, not only helps us treat you, but also diagnoses the issue as well, right? That helps us kind of figure out what's going on. I have some patients who are reluctant to try this, and some patients who are very happy. I'm a surgeon, right? But it's sometimes it's not the right thing to operate, and sometimes these non-surgical interventions are very helpful. And we have so many clinicians here that aren't just surgeons, who can provide these treatments for you. So this is generally where we start, unless there's some severe issue going on. But this is a good place to start. Next slide, please. Another intervention, now we'll go into surgical interventions, is what we call hip arthroscopy. So this is pretty cool stuff. So this is basically, we can get a camera into your hip with small surgical tools and actually operate within your hip through small poke hole incisions. This isn't laser surgery. It's still mechanical, but it's through these small poke hole incisions. And here we can treat smaller issues around the hip, like labral tears. In the picture on your right, you can see that's actually the hip labrum on the top with 2 sutures in it. So that's a repaired labrum. So we can repair labrums. We can also take care of some deformities around the hip, like we discussed earlier, in impingement deformities. We can take care of some tendon issues around the hip. And we have great hip arthroscopists that can provide this. Generally, if you have severe osteoarthritis or arthritis around the hip, that's when hip arthroscopy starts falling out of favor. And there can be this kind of, this purgatory between having severe arthritis and not. But once you have arthritis, oftentimes the results of hip arthroscopy aren't as great. And so we try to reserve for patients with some of those issues that we talked about before, trying to repair the hip before it becomes arthritic, taking care of that labrum, taking care of some of that impingement that you may have. Next slide, please. So then we talk about hip replacement. So hip replacement is the surgery I perform on a very regular basis. The hip replacement surgery is one of the most common surgical procedures performed in the United States. And it's been termed the operation of the century. And the reason for that is because of the pain relief and improvement in function that it provides patients. We used to, reserve hip replacement for patients in later stages of life, because the old hip replacements, the plastics used to wear out earlier. Today, our materials are much better. The wear rates of hip replacements are much lower, and patients are much more active. So we're actually performing hip replacement in younger patients nowadays than we did previously. In short, basically the hip replacement surgery, we remove the femoral head. We remove that nice circular ball that Danielle showed in some of her slides previously, because it's completely arthritic. It's no longer functioning appropriately, and we basically remove it. We prepare the femur for a metal stem with a ball on top, and we prepare your socket for a metal socket with that plastic liner. And that's your new hip joint. Reliable at relieving your pain, durable. It should hopefully last for a very long time. And in most patients, it lasts their lifetime. These implants your bone is supposed to grow into. Sometimes we use implants with bone cement, but generally we use implants that your bone grows into in most cases in the United States. Today, hip replacement is becoming much more technology friendly. We use oftentimes X-rays during surgery to get our components correctly. Sometimes we use computer navigation. Sometimes we use a robot, like the robot you see here, which all helps us get our implants in the appropriate position and customized to each patient specifically. Next slide, please. So I myself, I'm a hip and knee replacement specialist, but in terms of hip replacement, I mostly do anterior hip replacement. Anterior hip replacement has a little bit of a faster recovery in the early period, a little bit of a lower dislocation rate, and patients have been very happy with that approach in my hands. I also provide some robotic surgery, computer navigation surgery, and minimally invasive surgery as well. And usually patients see me when their arthritis is really bone on bone. They've tried anti-inflammatories, they've tried injections, they've tried physical therapy. And at this point in time, those things have no longer worked. And I think it's always wise to start with those things. But if they stop working and your quality of life is really affected, I think it's time to see a hip replacement specialist. And that would be the appropriate time. Next slide, please. So our focus all is you. I think HSS is a fantastic institution. We do the most hip and knee replacements in the region, and obviously we'd be very happy to treat you. And if you're having pain and you're having some severe hip arthritis, of course, I'd be happy to see you myself and get you back to all the activities you love doing. With that, I think we'll end at least my portion of the presentation. Thank you all.
I'm going to stop sharing this now, and we'll go into some questions with this last part here. So to start it off, there are a couple questions on osteoarthritis. So Dr. Debbi, I know you mentioned this, but someone asked if can the onset of hip pain due to OA come on gradually, or can it come on suddenly? Like, I know you said that's rare for it to come on very suddenly, but this person said she thinks it started over just a matter of days.
Good question. So the arthritis, the bone on bone part on your x-rays, or what's going on inside your hip, very rare for it to start, for that to occur suddenly. But oftentimes the pain when it starts, can be a surprise to patients. And when you do start having pain, oftentimes there's swelling around the hip and swelling inside the hip. And that swelling can be very painful and can take time to resolve. And that's why we use things like anti-inflammatory medication and injections to help reduce that swelling.
All right. And one other one about osteoarthritis. How can you tell the difference between pain from OA in the hip and versus the piriformis syndrome?
Great question. So piriformis syndrome is a challenging entity to exactly diagnose and treat, and it has to really do with where your sciatic nerve is traveling as compared to your piriformis tendon. It can be a little bit difficult to exactly diagnose and treat, and it's not entirely my field of expertise. But hip arthritis is typically very different from piriformis syndrome. Hip arthritis is generally, and not always, but generally groin pain. And it's groin pain with motion of the hip, such as flexion and movement of the hip in various directions, will typically cause groin pain.
All right, perfect. We'll move on to a couple about bursitis or tendonitis. One person asked how to sleep with bursitis pain. Best sleeping positions. Is sleeping on your side worse than on your back? And I don't know if, Danielle, if you want to chime in as well. Any tips for sleeping?
I'll just say, if it's the most common type of bursitis, which is typically trochanteric bursitis, sleeping on that side is going to be uncomfortable. So I wouldn't fight the pain. Some patients try to fight through pain. I don't think that's wise, because what can happen is it's a vicious cycle. You'll just exacerbate the pain even more, and then you won't be able to function. So the goal with bursitis or any type of inflammation of the body is to kind of put the fire out, rest it, take the anti-inflammatories, let it get better, then you can start sleeping on that side.
All right, I'm going to move on to impingement to cover a question about that. So how can you tell whether you have, impingement versus another type of hip condition, and what are the best treatments for impingement?
Great question. So the impingement can be difficult to diagnose only on a physical exam. I think that if you're having pain with impingement at 2, it can be groin pain, it can be pain in other parts of the hip. I think what would be very important is to get some x-rays with your clinician, and sometimes even 3D imaging like an MRI or a CT scan if necessary. That'll help most to see if the impingement is present, if those kind of anatomical abnormalities are there that can be causing some of the impingement. That's where I would start.
All right, thank you. And for some people asked about torn gluteal tendons. So treatments, surgical or otherwise, what's most effective for torn gluteal tendons? And can it heal with just physical therapy, say?
Great question. It really depends. It depends on how badly it's torn. The gluteal tendons are important for function. They're important even for just walking. And they're important to keep your hip and pelvis stable. Oftentimes they're a real nag when they're torn. It could be that you may not have severe pain. It could be that you do. So it's important to see how bad is your pain, how bad is your function, do you have weakness? When there's weakness, we start worrying that the function of the tendon is not there anymore. And then we start considering potential surgical intervention, such as repair. In other cases, we think about more inflammatory medication and injections as well. One helpful tool is an MRI scan because it does help us see how badly is it torn and how far off the bone could it be.
Okay, got it. So going into some treatment questions, Danielle, can you tell us, how someone can know when it's time for surgery, when it's time to, make that next step?
Yeah. So usually kind of when the pain or the symptoms are really affecting your activities of daily living, just such as like walking around, getting from point A to point B, sleeping at night, like you're not able to sleep or the pain is waking you up kind of every night. Or even, tying your shoes, you're lifting your leg over your other leg and, that's really exacerbating your symptoms. So definitely when it's starting to kind of affect your day-to-day activities. In addition to, when you have tried maybe some certain non-operative modalities or treatments, if indicated, such as like physical therapy. So you've tried a course of physical therapy, maybe medications such as non-steroidal anti-inflammatory medications. So a full course of that, seeing, your response as far as symptoms to that, or maybe certain injections, and seeing again response to that, as well as maybe ice or heat. And, if certain treatments such as non-operative treatments aren't really helping symptoms, or you're still experiencing symptoms that are affecting your daily life, that's kind of when take the next step and consider discussing with your clinician.
All right. So this is an interesting question. Some people might have, multiple causes of their hip pain simultaneously. This person has ankylosing spondylitis combined with previous traumatic injury or labral tear. So what can they do when there's competing problems with opposite solutions? So, that recommending rest versus exercise for the other problem. That's a complicated issue, I guess, but I don't know if you have any recommendations for that.
I think, obviously there, this is, a very difficult case where you have ankylosing spondylitis as well as prior injuries. But we see patients with pain in multiple parts of their body all the time. For better or for worse, arthritis likes friends. So if you have arthritis in one part of your body, there's a good chance you have arthritis in another part of your body. Unfortunately, it's a little bit like whack-a-mole. You got to treat what's the most debilitating, painful area first. And that goes both for non-surgical as well as surgical treatments. The hip specifically, because it's such a large joint and because we use it in so many functional activities, typically is one of the first we treat if you have severe pain in that location. Otherwise, what I would try are potential injections in areas that may not be as painful. For example, ankylosing spondylitis, there could be some pain in the sacroiliac joint or pain in other parts of the body that can be treated to allow some focused real therapy for another part of their body.
Okay. I know you talked a lot about injections already, but specifically, would a cortisone shot in the piriformis muscle help that syndrome? And could that confirm a diagnosis of that?
I'm not an expert on piriformis syndrome and injections. I know that has been done previously and it could help. What I would do is meet with a pain management specialist or a physical medicine and rehabilitation doctor to get a better diagnosis of that area and potential MRI scans. It can be a very difficult syndrome to fully diagnose and treat.
Okay. How do injections help someone with bone on bone, which you might have mentioned this briefly, but what's the benefits for someone with bone on bone getting injections?
So it's a great question. What's important to realize, just to take a step back, is unfortunately, once it's bone on bone, the cat's out of the bag. There's no kind of backpedaling. There's no, make the hip, back to what it used to be and put the cartilage back. And there's no injection that's really going to do that. There's no proven injection to regrow cartilage. The goal is pain management. Cortisone injections is one of the first lines of injections, and the goal is really to see if we can kind of put out that fire of inflammation. If we can put out that fire of inflammation, then maybe you can go back to physical therapy, strengthen the hip, and maybe the pain is actually not as bad as it could be. Unfortunately, and if it really is bone-on-bone arthritis, many times hip injections aren't successful in the long run and can be temporary pain management relief. Which isn't necessarily bad. We have patients who, they have an important wedding they have to go to. Their grandchild's about to be born. They have to work for the next few months. We need to kind of bridge them. We got to say, okay, we'll do the injection. Let's bridge you. If it comes back, we'll do the hip replacement. Every case is different. Our goal is to really kind of tailor what we need to do for you specifically.
All right, thank you. I'm going to skip to one that for you, Danielle. Someone asked, can spinal stenosis or pinched nerve in the lower back then cause hip pain?
Yeah, so depending on where the stenosis is or compression in the spine may definitely cause hip pain for sure. That's kind of why a detailed history is important and kind of being as precise as possible in regards to your symptoms when you're discussing with your clinician is very important. Here at HSS, we take like a multidisciplinary approach where other imaging can be done relatively easy if warranted, or referrals to other specialists can be made based on certain symptoms that you're experiencing.
All right. So now we got quite a few questions about hip replacements, which I know you have a lot of expertise in, Dr. Debbi. So let's look at a few of those.
Sure.
Can you talk a little bit about hip pain that persists after having total posterior hip replacement? If they're still experiencing hip pain, they have bursitis, I believe.
Sure. So, I think that pain after surgery is a difficult issue, right? That one kind of goes a little bit beyond the scope of causes of native hip pain. There can be a whole laundry list of issues that could be wrong with a hip replacement. Thankfully, the vast majority of hip replacements are doing fantastic. But obviously there could be issues. Some of them are minor, some of them are the same issues you have, patient without a hip replacement can have, like bursitis, piriformis syndrome. You shouldn't really be having things like labral tears or impingement because the hip there is no longer there, but there could always be other issues like sciatica. I think it's really important that if it's related to the hip replacement, the most important thing is to really meet with your surgeon specifically. They're going to be the person that's best able to help you. And the reason for that is that they were in the hip. So they know your anatomy, they've been there, they know what implants you needed, they know the complexity, and you have that rapport. And obviously, I'm sure they want to see you get better. So that's going to be the most important person to meet with.
All right, makes sense. This person wanted to know, can you discuss the pros and cons of anterior hip replacement versus posterior hip replacement? My understanding is that the healing process is quicker and anterior, is anterior becoming more common? Is that true?
So it's a great question. We could kind of debate this all day. And I just gave an hour talk on this a few hours ago. There's no perfect answer. And while I do mostly anterior hip replacement, I also do posterior hip replacement for the patients for which that's a better surgery. There are some studies showing that anterior hip replacement have a little bit of a faster recovery time in the early postoperative period, up to about 6 weeks. And they kind of come off their assistive devices a little bit faster than posterior hip replacements. In the long term, most of these patients really become very equal. So long term, there aren't very significant differences between the approaches. There are some studies also suggesting that the risk of dislocation after hip replacement is a little bit lower with the anterior hip replacement. But with better implants and better technology, I think that difference is becoming a little bit smaller.
All right, interesting. I'm going to give just one more, and in interest of your time. Why should I consider hip resurfacing surgery versus hip replacement surgery?
Great question. Another kind of debatable topic for a long period of time. Most patients are good candidates for hip replacement surgery. There are a subset of patients who could be candidates for hip resurfacing. They're generally younger patients, more highly active. It really depends on bone quality and consideration as to the activity level of the patient. Most of my patients, the vast majority, are undergoing hip replacement rather than hip resurfacing.
All right, got it. Okay, I think that's all the questions we're going to do for today, just in the interest of time. We really appreciate you guys doing this and answering all of these questions.